It's my pleasure to speak on this important topic, the clinical use of stress echo in non-ischemic heart disease. This is certainly a burgeoning area of our practice at Mayo Clinic, and to share with you the recently published recommendations, which are a collaborative effort from the ASE and the EACVI. These recommendations were published in the February issue of Journal of the American Society of Echocardiography and also published in the European Heart Journal Cardiovascular Imaging. They represent the collective agreement and input from colleagues in Europe, Canada, South America, and South Korea. The objectives of our webinar today will be to appreciate the indications for stress echocardiography in assessment of non-ischemic heart disease, to understand the most appropriate type of stress modality, whether it be bicycle, treadmill, pharmacologic stress for a given situation, and to determine the optimal imaging protocol for a specific situation, because there are so many things that we can measure with echocardiography and Doppler. This is a list of the various conditions that can be assessed with stress echocardiography. Now, most commonly, we use stress echocardiography to evaluate patients with known or suspected ischemic heart disease. In this circumstance, we are looking for new or worsening regional wall motion abnormalities with stress, and stress echocardiography has been shown to be more accurate than the exercise electrocardiogram. Displayed here is an example of a normal exercise echocardiogram. In these parasternal images, we can see the augmentation of ejection fraction and decrease of end-systolic size with the stress of exercise. However, stress echocardiography can also be applied to assessment of diastolic function, pulmonary hypertension, cardiomyopathy, valvular heart disease, including patients who have had valvular procedures, athletes' hearts, and congenital heart disease. The amount of evidence for stress echocardiography in assessing these different conditions does vary somewhat. However, stress echocardiography can be helpful in some very challenging clinical circumstances, as we will see. Now, resting Doppler echocardiography unequivocally provides a great deal of information. We can accurately delineate cardiac anatomy, like in this nice example of the short axis view of a quadricuspid aortic valve, and we can quantify valvular disease. And you can see a vena contracta in this patient with significant aortic regurgitation. We can also assess systolic and diastolic function. However, resting Doppler echocardiography does not allow us to assess the cardiac response to stress or to assess the functional consequences of cardiovascular disease. However, with stress, either physical or pharmacologic, these structural and functional cardiovascular abnormalities might develop, and we can assess them with stress echocardiography. These various stressors, exercise, dobutamine, and vasodilators, can induce a mismatch in myocardial oxygen supply and demand and can induce ischemia in the presence of a reduction in coronary flow reserve. With exercise, we can expect to see a 2 to 3-fold increase in heart rate, a substantial increase in systolic blood pressure, and a marked increase in myocardial contractility in the normal heart. With dobutamine in the normal heart, we also see a marked increase in heart rate, especially if we include atropine administration. Systolic blood pressure increases, but considerably less than with exercise, and we again have a marked increase in myocardial contractility. With vasodilator stress, the increase in heart rate is much more modest. Blood pressure typically decreases a bit, and contractility increases only modestly. Now there are these various methods that can be combined with echocardiography to do a stress test. Exercise is indeed the most physiologic form of stress testing, and therefore in patients who are able to exercise, it is the test of choice. We are all very familiar with treadmill exercise protocols, but bicycle exercise, whether it be supine, upright, or semi-supine, allows us to image the patient during the stress of exercise, and therefore it is often used when we want to get additional Doppler parameters during the stress echocardiogram. Then we're not left to try to gather all sorts of information during the immediate 1 minute after completion of a treadmill exercise test. However, either works. Pharmacologic stress can be performed with dobutamine. We use this to assess contractile reserve, and it's most often used in patients with reduced ejection fraction and suspected severe aortic stenosis. Vasodilators can be used to assess coronary flow reserve and may be helpful in patients with dilated cardiomyopathy. However, most of our discussion today will center on exercise testing and a lesser degree on dobutamine testing. For our stress echo protocols, the Bruce protocol is usually used when we do treadmill stress testing. This has 3-minute stages with a progressively increasing ramp and speed. The modified Bruce protocol is a more gradual protocol used for patients with a lower exercise capacity. It begins at 1.7 miles per hour and 0% grade, and then in the second stage, the grade increases. Note the setup to our stress echo laboratory. The treadmill and echo bed are very close in proximity, and this is important so that there's no delay in getting the patient from the treadmill to the echo bed. For bicycle echo stress testing, we generally start at 25 watts and increase by 25 watts at 3-minute intervals. So this is the workload on this scale, and time is on this axis. There are many, many things that we can measure, and so you need to have a strategy for what is going to be measured, what is most important at the time of the test. We can measure left ventricular systolic function, regional wall motion, E to E prime, mitral regurgitation, the gradient across the valve, systolic pulmonary artery pressure, and right ventricular function. So the patient will be pedaling against an increase in workload at a constant cadence, like with a metronome. And at 3-minute intervals, the workload increases. We monitor blood pressure, electrocardiogram, and the patient's clinical condition. Now, you can use longer stages, whatever your lab decides to use, but a standard protocol is a good idea to have so that you can make serial comparisons between patients and for the same patient. It's good to obtain your measurements at the different stages of exercise because an increase in systolic pulmonary artery pressure that occurs at a very low level of exercise certainly has a different connotation than one that occurs at a very high level of exercise. So the rate of change of these parameters is also important. Shown here are the diagnostic endpoints. On the left-hand side, the causes of test cessation in the middle, and criteria for an abnormal test on the right-hand side. Diagnostic endpoints include achieving a maximum dose or workload, achievement of target heart rate, obvious ECG positivity, and obvious exercise echo or stress echo positivity, and severe chest pain. In our laboratory, we really like the patient to exercise maximally until they're exhausted, and so we tend to not stop for any particular heart rate threshold. If we're doing a pharmacologic test with dobutamine, then the target heart rate and maximum dose become important. Causes of test cessation include intolerable symptoms, exhaustion, hypertension, and a blood pressure of 220 over 120 is suggested, symptomatic hypotension, and a 40 millimeter mercury drop in blood pressure is suggested. Significant arrhythmias would also be a reason to stop the test. Abnormal tests may be defined by the development of symptoms at a low workload, particularly in a patient with valve disease that seems severe, but the patient reports being asymptomatic. You can see if they indeed are asymptomatic or if they develop symptoms. We also look for ischemic ECG or wall motion findings, significant arrhythmias, and then there are specific targeted features, such as the development of a more than 50 millimeter mercury interventricular obstruction in a patient with hypertrophic obstructive cardiomyopathy. This shows our dobutamine echo protocol. And so when we do dobutamine testing for patients with a non-ischemic protocol, or where we're looking at an inotropic response in a heart failure patient or need to measure multiple valve parameters, we usually use 5-minute stages to give us a little more time to get these parameters as the heart rate gradually increases. It may take a little bit more time to get the full contractile reserve response to dobutamine. We usually need to only go up to a peak dose of 20 micrograms per kilogram per minute when we're not doing ischemia testing with dobutamine. But in some patients where you're looking for contractile reserve, if the patient is heavily beta blocked, they may need the full 40 micrograms per kilogram per minute. Atropine is usually not required unless you're also looking for ischemia. So our report should include the protocol that was used and the heart rate and blood pressure responses. It also needs to include the dose of dobutamine, atropine if it was used, and then the changes in our parameters, whatever we're measuring, whatever the subject of interest is, such as the valve area and left ventricular outflow tract velocity and time velocity integral. Let us consider now the application of stress echo to assessment of diastolic function, pulmonary hypertension, or the patient with dyspnea. Now, diastolic dysfunction is recognized to be the main cause of heart failure symptoms in about 40% of patients with heart failure. So it's really important to recognize, and sometimes it isn't obvious from our resting echocardiogram. With our diastolic stress echo, we might consider applying this to symptomatic elderly patients, those with diabetes, hypertension, obesity, or sedentary lifestyle who experience symptoms of dyspnea, breathlessness, or exertional fatigue. With our diastolic stress echo, we will be evaluating changes in the E' velocity with stress, the stroke volume and cardiac output reserve. We'll be looking at the E to E' ratio and the systolic pulmonary artery pressure. We will be able to detect heart failure with preserved ejection fraction in some patients. We can also look for these other parameters, particularly the development of ischemia that might contribute to the symptoms, or dynamic intracavitary obstruction, dynamic mitral regurgitation, or clonotropic incompetence, which might explain the patient's symptoms. When we're doing this diastolic stress echo, you have to decide whether you're going to measure the septal or lateral wall E' or to average them. Our laboratory measures the medial or septal E prime, and we look for a ratio of, with exercise, of more than 13 to 15 being abnormal. The diastolic function guidelines recommend that a rest peak tricuspid regurgitation velocity more than 2.8 meters per second and a rest septal E prime velocity less than 7 centimeters per second are abnormal. However, let's see how we might apply this with exercise. Now here's a clinical example from our practice. This is a 73-year-old woman with very significant class 3 exertional dyspnea. She had a history of hypertension for which she was taking a diuretic. Here is the images from her exercise echocardiogram, and you can see that this looks normal. There's a nice increase in ejection fraction with the stress of exercise. She exercised for 4 minutes of a boost protocol, stopped because of shortness of breath. Her heart rate and blood pressure responses were satisfactory. Blood pressure was a little bit high to begin with at 148/80. Here are her hemodynamics at rest. The E to E prime ratio was 11, and the left atrial volume index was 34. So really kind of at the borderline. And I think that if you consider this and think of how you might answer this, how would you grade this patient's diastolic function? Is it normal, or is it delayed relaxation, pseudonormal, restrictive, or can't you tell? I think it's hard to say whether it's normal or pseudonormal with these data. However, with the exercise test, we measured her tricuspid regurgitation velocity and the E to E prime ratio, and it becomes straightforward here. The E to E prime ratio increased from 11 to 21, and you can see that there is clearly an abnormal response. Whereas a normal patient will increase their E velocity, they also increase the E prime velocity, and therefore the ratio doesn't change. But here we have a marked increase in E to E prime ratio and an increase in tricuspid regurgitation velocity. And I think this all explains or corresponds to the patient having significant diastolic dysfunction and some mild pulmonary hypertension that account for her exertional symptoms. When we apply stress echo to assessment of pulmonary hypertension, it's important to know what should be expected. The tricuspid regurgitation velocity or pulmonary regurgitation velocity, if you're measuring that, will increase with the stress of exercise as blood pressure increases. We have published normal values demonstrating the impact of age on the systolic pulmonary artery pressure at rest and with exercise, and that's shown on the right-hand side here. You can measure the peak velocities, but on the right side of the heart, but also right ventricular size and function. You can measure lateral annulus, S prime, TAPSE, systolic strain, left ventricular size and function, and right atrial pressure. It can be helpful also to measure oxygen saturation with a pulse oximeter. This shows an example of a patient with significant exertional dyspnea. Now, most cases aren't this obvious, but you can see here that the right ventricle has dilated with the stress of exercise and the septum has become D-shaped and flattened. This was associated with an increase in right ventricular systolic pressure from 39 to 78 millimeters mercury, and indeed an elevation in pulmonary artery pressure or development of right ventricular dysfunction with exercise has been associated with a poor prognosis. What about the application of stress echo to assessment of cardiomyopathy? It has been applied to assessment of ischemic heart disease and viability testing, also to dilated cardiomyopathy. You can use this stress echo to evaluate contractile reserve in a patient receiving chemotherapy. And we might even use dobutamine to predict response to cardiac resynchronization therapy or beta blocker therapy. We usually use this in our practice to evaluate patients with hypertrophic cardiomyopathy who are symptomatic. Our protocol in our laboratory is to try to get the gradient up to 50 millimeters mercury, which is the threshold for intervention. On our rest echo, we'll see if this type of gradient is present. Then we'll try a Valsalva maneuver. If we still haven't gotten it to 50, we'll give amyl nitrite. And if this still doesn't produce the gradient in a symptomatic patient, we'll do an exercise echo. We don't do dobutamine testing in these patients because dobutamine can produce a artificial obstruction even in patients without hypertrophic cardiomyopathy. So it's just not physiologic. So for exercise echo and hypertrophic cardiomyopathy, it has been shown that markers of worse prognosis are a limited exercise capacity, abnormal blood pressure response, significant ST segment depression, inducible wall motion abnormalities, and exercise-induced left ventricular outflow tract obstruction of more than 50 millimeters mercury, and blunted contractile reserve. So exercise echo also allows monitoring of the efficacy of therapy in an individual patient, and we found it to be very useful in our practice. Here's an example of a patient who came to our lab for an exercise echo. You can see a patient with hypertrophic cardiomyopathy. There is acceleration of flow in the left ventricular outflow tract. This was accompanied by this late peaking increased velocity Doppler profile. But with the stress of exercise, we did our usual stress echo, had the patient lie down, and the patient said, I get the symptoms if I stand up. So we had the patient stand up right then after stopping exercise, and you can see that there's significant mitral regurgitation that develops. The dynamic obstruction appears worse, and this really offers a nice explanation for the patient's symptoms, although you can see that the mitral regurgitation and the left ventricular outflow signals are somewhat blended in this Doppler profile. Now, stress echo can also be applied to assessment of challenging patients with valvular heart disease, and this is a very exciting and growing area of our practice. With valvular heart disease, we can evaluate patients with mitral regurgitation, mitral stenosis, aortic stenosis, or aortic regurgitation, where the severity does not seem to match with the symptoms. That is, the patient appears to have only moderate disease, but is reporting symptoms. We can also use it to evaluate the patient with significant, moderate to severe, or severe valvular heart disease who says that they are asymptomatic, to see if they really are. With these studies, we will be evaluating the patient's symptoms, change in blood pressure, and exercise tolerance. Now, there are many things that we can measure. We can measure the change in gradient across the valve in the patient with aortic stenosis or mitral stenosis, and indeed an increase of more than 18 to 20 millimeters mercury in aortic stenosis has been associated with a worse prognosis, as has a mean pressure gradient of more than 15 to 18 with mitral stenosis. We can look at the change in effective regurgitant orifice area in mitral regurgitation. We can also look at the ventricular responses to the stress, including whether the ejection fraction increases appropriately. We can also look at changes in global longitudinal strain, which should be increasing with the stress of exercise. We want to see an increase in stroke volume. A failure of this to increase by 20% is abnormal, and we can look for ischemic wall motion abnormalities to develop. We can also appreciate left and right ventricular dyssynchrony. Hemodynamic effects that we can watch for are a change in the E to E prime ratio and the development of pulmonary hypertension. All of this information can be used to match patient symptoms with cardiac involvement, to stratify risk, and to help guide decision-making and to find the optimal time for intervention. Let us consider the circumstance of mitral regurgitation. Now, we know that this is a dynamic condition and dependent on load. We would like to use exercise stress rather than dobutamine unless ischemia is suspected as the primary cause of mitral regurgitation, just because dobutamine is less physiologic. When mitral regurgitation is already severe at rest, our image acquisition should focus on systolic pulmonary artery pressure, left ventricular contractile reserve, and exercise limitation. Mitral regurgitation severe at rest it's not important to redocument that it's severe with stress. With primary mitral regurgitation, let us review this example from the writing group on exercise echo in mitral valve prolapse. Here you can see at rest, the ejection fraction is normal and global longitudinal strain is normal. However, with the stress of exercise, there's a lack of contractile reserve. The ejection fraction stays the same, and the global longitudinal strain also failed to increase as expected. Here we can see the tricuspid regurgitation velocity that increased. We can also see an M mode of the flow convergence zone documenting an increase in mitral regurgitation. And we can see an increase in the Pisa radius on the right-hand side with the stress of exercise. All this corresponds with an increase in mitral regurgitation severity with the stress of exercise. It should be noted that this Pisa measurement can be quite challenging with exercise, and sometimes other parameters are easier to measure, including tricuspid regurgitation and the ventricular response to stress. In the case of secondary mitral regurgitation, we evaluate this in patients with exertional dyspnea that seems disproportional to mitral regurgitation at rest. This can be helpful in the patient with unexplained pulmonary edema. It might also be helpful in determining which patient should undergo mitral valve intervention at the time of scheduled coronary artery bypass grafting. It can also be helpful in evaluating persistent pulmonary hypertension after mitral valve repair. In this example, we see there was the development of lateral wall ischemia in a patient who had a stenosis of the LAD. This patient ended up requiring mitral valve repair and one vessel bypass grafting. You can see the marked increase in mitral regurgitation. This was accompanied by an increase in right ventricular systolic pressure in this patient. What about stress echo in aortic regurgitation? Indeed, there is much less experience applying stress echo to this group of patients. However, it's useful to reveal symptoms in the patient with severe aortic regurgitation who reports no symptoms and lacks surgical criteria for aortic valve replacement, namely an ejection fraction of less than 50%, left ventricular end systolic dimension of greater than 50, or an indexed LVESD of more than 25 millimeters per meter squared. Remember that stress-induced increase in heart rate will shorten diastole, so it's not helpful to try to quantitate aortic regurgitation severity with stress. But this can be helpful in confirming equivocal symptoms. One of the things that we look for in particular in asymptomatic severe aortic regurgitation with exercise echo is contractile reserve, which is defined as an increase in ejection fraction with exercise. Now, of those patients who lack contractile reserve, it's been shown that ejection fraction tends to decrease at follow-up, and this has been true for patients who are managed medically or surgically. Tissue Doppler imaging can also be used to assess rest and exercise longitudinal function, and it might be helpful to evaluate views of the left ventricle in particular, also tissue Doppler imaging, systolic pulmonary artery pressure, and even color flow assessment of mitral regurgitation. For patients with mitral stenosis, we have found in our practice at Mayo Clinic that exercise echo is particularly helpful. It's helpful in patients with severe mitral stenosis, and that is defined by these mitral valve areas according to different guidelines, to reveal symptoms, to see if the patient really is asymptomatic. But it's also especially helpful, I think, in patients with non-severe mitral stenosis who have symptoms to understand what's going on in these patients. Guidelines for valvular heart disease now give stress echo for mitral stenosis a class 1 indication when there's a discrepancy between resting Doppler and clinical findings and symptoms. So this is the case when there's an intermediate mean gradient in valve area. And we can use it to predict the efficacy of valvuloplasty when there's a doubling of transmitral gradient or the gradient goes to more than 15 millimeters mercury. There's less data for dobutamine stress echo, but some saying that if the gradient with dobutamine the mean gradient exceeds 18 millimeters mercury, that this will predict efficacy of intervention. You can also predict that the patient will benefit from intervention if the systolic pulmonary artery pressure associated with this increasing gradient exceeds 60 millimeters mercury. So here's an example from our practice. You can see the changes in the gradient across the mitral valve with the stress of exercise and the increase in tricuspid regurgitant velocity with the stress of exercise. One more thing that you'll want to do in these patients is do color flow assessment of mitral regurgitation, because sometimes these patients will develop more mitral regurgitation and with exercise, and you don't want to send such a patient off for a balloon valvuloplasty, which is apt to increase the mitral regurgitation. So here's an example from our practice, 60-year-old woman who had had a mitral valvuloplasty 11 years previously and had done very well. But recently she's developed shortness of breath. The mean gradient on the rest echo was 8 millimeters mercury across the mitral valve. The mitral valve area was calculated at 1.2 by pressure half-time method, 1.4 by continuity. And here you can see that tracing of her mean gradient. And her right ventricular systolic pressure at rest was 34 millimeters mercury. She did a supine bike exercise echo, and you can see that her wall motion is completely normal at rest and with exercise. She exercised for 100 watts. Heart rate increased from 71 to 146, and her blood pressure increased, got quite high with the stress of exercise. You can see that she doesn't develop any significant mitral regurgitation, but the mean gradient across her mitral valve increased to 30 millimeters mercury, and her right ventricular systolic pressure increased to 70 millimeters mercury. So this is a patient who required reintervention. Now, exercise echo can also be applied to asymptomatic severe aortic stenosis. And in such a patient, predictors of cardiac events include a valve area of less than 0.75 centimeters squared, or with exercise, the development of symptoms, an abnormal test, which would be defined as marked ST segment depression, hypotension, marked ECG abnormalities. An increase in mean gradient in this study by Lancelotti across the aortic valve was also associated with worse outcome. We looked for abnormal left ventricular functional reserve and marked increase in systolic pulmonary artery pressure. So you can see the incremental value, looking at the rest echo, adding the exercise ECG, and then finally adding the exercise echo. Here's an example from our practice. This is an 82-year-old man who was asymptomatic. His mean gradient at rest was 45 millimeters mercury, and his Doppler-derived aortic valve area was 0.81 centimeters squared. You can see that his left ventricular systolic function appears normal in this parasternal long axis view. His walls look mildly hypertrophied, and you can see that his aortic valve is calcified with marked restriction of opening. So this fits with severe aortic stenosis. However, the patient insisted that he was asymptomatic. We performed a supine bicycle exercise test in this patient. He exercised to 7 METs and developed fatigue. His baseline image here in an apical long axis view is shown. And again, you see normal ejection fraction and symmetric increase of the anteroseptum and infralateral walls. With the stress of exercise, his blood pressure initially went up, but at peak exercise, his blood pressure fell. So a concerning finding. And here's what was going on with his left ventricle at that time of that decrease in blood pressure. This is an apical 4-chamber view and an apical long axis view. And you can see that his left ventricle has dilated and his ejection fraction has decreased. So this is evidence that his ventricle really is not tolerating the stress of exercise. And therefore, based on this, the patient was referred for aortic valve intervention. Now, dobutamine stress echocardiography can also be applied to the patient with aortic valve disease. We use doses of 5, 10, 15, and 20, sometimes higher with beta blocker therapy in these longer stages. We monitor heart rate, blood pressure, electrocardiogram, and the clinical status. We usually use this when the patient has reduced ejection fraction. And we'll be looking for changes in left ventricular systolic function, the development of regional wall motion abnormalities, but also assessing the stroke volume, left ventricular outflow tract time velocity integral, and aortic valve time velocity integral, and the mean gradient across the aortic valve. Then we'll use the baseline left ventricular outflow tract diameter, which has been shown not to change during dobutamine stress testing, and recalculate the aortic valve area. Here's how we apply dobutamine stress echo to classical low-flow, low-gradient aortic stenosis. So this is the patient with reduced ejection fraction, a valve area that appears to be in the severe range, less than 1 centimeter squared, but a mean pressure gradient that is not severe. And we're trying to sort out whether this indeed is severe aortic stenosis. So with low-dose dobutamine, we try to get the stroke volume to increase to more than 20%. If we can achieve this increase, then we also look for an increase in the mean pressure gradient. We will recalculate the aortic valve area under different hemodynamic circumstances. With true severe aortic stenosis, the valve area remains less than 1 centimeter squared, and this patient would be expected to benefit from aortic valve intervention. In fact, it may be the aortic stenosis that is causing the left ventricular systolic dysfunction. On the other hand, in the circumstance of pseudo-severe aortic stenosis, we might note that the valve area actually increases, and the mean gradient does not exceed 40 millimeters mercury. This patient would be expected to benefit more from a treatment of their heart failure than from their valve. Some patients will not augment their stroke volume even with a low dose or a high dose of dobutamine. These patients are thought to have a fibrotic left ventricle and may not benefit from intervention. However, you might consider intervening anyway, as we have little to offer these patients. And it has been suggested that using the calculated projected aortic valve area, which involves using an equation detailed in the paper that involves aortic valve area at rest plus the valve area and flow term changing with dobutamine, to determine this parameter might be helpful. Another way to evaluate these patients would be to assess the calcification of the aortic valve using CT. Stress echo can also be used to evaluate the patient who has had a heart valve procedure. This has been applied to patients who have an aortic or mitral prosthetic valves, mitral valve annuloplasty, and can be useful when there's a discordance between symptoms and resting hemodynamics. In these patients, we usually use bicycle exercise, but dobutamine is sometimes used if the patient is unable to exercise. We can use this to identify prosthetic valve stenosis or patient prosthesis mismatch. A disproportionate increase in the mean gradient is considered to be more than 20 millimeters mercury with an aortic valve prosthesis or more than 12 with a mitral valve prosthesis or repair. And we also watch for the development of symptoms. What about athletes and patients with congenital heart disease? Stress echo can also be applied to these groups. It can be helpful in athletes with exertional symptoms in order to detect ischemia, development of interventricular gradients, pulmonary hemodynamics, mitral regurgitation, and you can also look at B lines with lung sonography. It can also be helpful in patients with borderline rest ejection fraction to see if ejection fraction is normal or abnormal. Of course, the normal response is an increase with exercise. In patients with congenital heart disease, there is less evidence for application of stress echo. Nevertheless, it can be helpful in patients with atrial septal defect to evaluate right ventricular performance and contractile reserve and systolic pulmonary artery pressure at rest and with exercise. It has also been applied to patients with tetralogy of Fallot to assess right ventricular and left ventricular contractile reserve. We can use it for treated coarctation. And in these patients, we assess the blood pressure response and residual gradient and myocardial response. If the gradient across the coarctation, usually measured from the arch, exceeds 30 millimeters mercury with exercise and the patient has systemic hypertension, such a patient may need additional treatment for coarctation. In patients with a univentricular heart, there are few data, but it can be useful to monitor serial responses in an individual patient to see how they're doing. With the systemic right ventricle, we can assess contractile reserve. This image on the right-hand side shows an exercise echo in a patient with situs inversus and congenitally corrected transposition, where the morphologic right ventricle is a systemic ventricle. Here, increased myocardial thickening and a decrease in right ventricular and systolic volume, that is a normal response, were observed. So in summary, stress echocardiography is an extraordinarily versatile technique. It has many possible applications in the patient with non-ischemic heart disease. Our evidence is still evolving, but I think this technique is ready for clinical practice and application to some of our most challenging patients. It can be used for diagnosis as well as risk stratification. It lends itself to serial assessment for follow-up and evaluating response to treatment. Guidelines specifically recommend the use of stress echo in evaluation of certain patients with dyspnea, where we're suspecting diastolic heart failure, but also valvular heart disease and hypertrophic cardiomyopathy. If the patient is symptomatic and we do not achieve the expected gradient of more than 50 millimeters mercury with rest or other maneuvers. We need further information about its role in the evaluation of patients with congenital heart disease and pulmonary hypertension. In all of these patients, we can combine our Doppler assessments and other parameters with our wall motion assessment for ischemia. In the future, we will likely be using deformation imaging and multidimensional imaging in our assessment and use of stress echo in non-ischemic heart disease. And with that, I'd like to take your questions, so please send them in. I'm looking at your questions now that you've sent in. There's a question, at what time during the 5-minute stages do you begin imaging in dobutamine stress echo? That's a good question. It depends a little bit on how difficult our sonographer expects the imaging to be. For example, if we're going to be rolling the patient into the supine position or even onto their right side for right supraclavicular or right parasternal imaging, we might begin a bit earlier. However, we usually start after about 2 to 3 minutes into the 5-minute stages. There's a question about assessing diastolic function and bike being the gold standard, since there's lots of parameters to be assessed. I think it is useful to use bike exercise whenever we have a lot of Doppler parameters. It just gives you so much more time to assess these at peak exercise rather than to be scrambling to get everything in immediate recovery. However, it depends a bit on the patient. Patients do tend to exercise better on a treadmill, at least our patients in the U.S., than on a bicycle test. So I think either works, and we tend to leave it up to the clinician or the person, the cardiologist that will be interpreting the test to determine. We do have the option here at our center to order a bicycle hemodynamic study, and that's what we would do for most of these patients. There's a question about which parameters we use to evaluate contractile reserve and what is normal. So I think the most commonly used parameter is stroke volume, and we expect to see an increase of about 20% from the baseline. However, you can also use ejection fraction. We should see an increase of at least 5% with the stress test. You can also do global longitudinal strain, and we should see an increase of -2 for global longitudinal strain, but usually even more than that. There's a question about the gradient more than 50 millimeters mercury. When we're using that in hypertrophic cardiomyopathy, we're just talking about a maximum instantaneous gradient rather than a mean. When we're evaluating gradients in patients with aortic stenosis and mitral stenosis, we measure mean gradients. There's a question about whether there's a role of dobutamine echo in paradoxical low gradient aortic stenosis. I think that this is a subject on which we still need more data. Paradoxical low gradient aortic stenosis refers to the circumstance where the ejection fraction is normal, but the stroke volume index is low. Dobutamine may be helpful in those patients, but we do need more data. So if any of you are interested in publishing that, I think that would be great. There's a thought on the use of atropine with bicycle stress echo or dobutamine stress echo and how it might affect results. I think the role of atropine is best demonstrated in patients with undergoing dobutamine stress testing for ischemia. There it clearly has been shown to increase the sensitivity of the test, particularly in patients who are on beta blocker therapy. I think its role with supine bicycle stress echo is less certain. We have tried an atropine study in patients undergoing a treadmill test and published these results, Dr. Attenhofer, several years ago, to see if it would help keep the heart rate up longer in the recovery period to allow more time to get the post-stress imaging, keep the heart rate up higher. But even giving atropine, the heart rate decreased exponentially in recovery. There's a question about assessment of diastolic function and whether we can use E to E prime when there's fusion of the E and A waves. That's a good question. I think that it is best to wait until the E and A waves are a bit unfused. You know, there's a point at the test when they're completely fused and you really can't tell what's going on. Our approach is to assess wall motion and ventricular function first, tricuspid regurgitation velocity second, and then to go for the E to E prime if we're doing a treadmill test. If we're doing a bicycle test, then we would measure the E to E prime before the patient gets to maximal exercise, and then again in recovery. So I think it is important not to be measuring data that is completely fused, that might be contaminated and hard to interpret. There's a question about a protocol for the exercise echo. We use the protocol that is published in the document using the usual 3-minute stages and starting at 25 watts and increasing by 25 watts at each stage. There's a question about when to get the Doppler data during post-exercise imaging to compare resting images and post-exercise images. For 5-stage stress echo view, I think when you're deciding which information to put in your quadrants for the 4 stages, we usually do baseline images, low level of exercise, peak exercise, or pre-peak exercise and peak exercise, or you can obtain pre-peak dobutamine and peak dobutamine. If the patient gets to peak exercise abruptly, then you can put immediate recovery in the last quadrant. There's a question about whether a complete 2D echo is needed before performing a treadmill stress echo. We don't require that. We do, if the patient has not had a complete transthoracic echocardiogram, we do sort of a limited screening echocardiogram at the time of our stress echo. We want to make sure that it's safe for the patient to exercise, that we're not overlooking any significant valvular heart disease or severe valve disease or severe unsuspected pulmonary hypertension, but we don't require full transthoracic echo. And I think as we go forward and try to think of how we might evaluate our patients most efficiently and most cost-effectively, we might be increasingly combining the tests. You know, I could foresee in the future a patient with valvular heart disease being referred to the echo lab, and depending on what you find, you might or might not decide to do the stress echo after the transthoracic study. There's a question about using strain imaging to assess diastolic function, particularly looking at strain rate. That's an interesting question. The strain rate signals do tend to get sort of messy with stress testing. I think more data is needed about that. I think diastolic function assessment is also challenging, and more data is needed on that as well. The time for diastole, of course, becomes more abbreviated as the heart rate increases, and so diastolic function assessment with strain imaging might be quite challenging. I think for pathology that is best evaluated by bicycle versus treadmill exercise, I think mitral stenosis is a good example of where we routinely use bicycle exercise. I like to look at the color flow assessment of the mitral valve as well as the mean gradient as well as the tricuspid regurgitant velocity. And then we can also look for regional wall motion assessment in these patients with mitral stenosis and exertional dyspnea that seems disproportional to the resting hemodynamics. Vasodilation stress echo, there's a question about that. I think that other groups outside the U.S., particularly our colleagues in Italy, have, and also some colleagues in South America, have more experience using vasodilator stress echo. They use it especially for looking at coronary flow reserve. There's also good evidence for its application for ischemic heart disease. For diastolic stress echo, there's a question about whether we should use bicycle or pharmacologic stress echo. I would recommend using bicycle stress echo or treadmill stress echo in these patients rather than pharmacologic stress, just because bicycle is more physiologic. There's a question about the most frequent technical problems for exercise stress echo. I think the technical tips are to get to make sure that your team performing the test becomes very comfortable with your protocol and understands clearly what you're trying to achieve with the test, what your priorities are. If regional wall motion is the most important priority, and then you want to assess diastolic function as a secondary issue, then your sonographer must do the two-dimensional images looking at all the segments first. So just having a strategy for with you and the person performing the stress test as to your imaging objectives is very important. The room setup is also important. Having an echo bed with a cutout window helps facilitate imaging, making sure that your room is set up to minimize any time or delay getting a patient from a treadmill to the echo bed is important. These technical tips can go a long ways towards success. There's a question about the addition of contrast for stress echo in valvular heart disease. The contrast can help you detect regional wall motion and evaluate ventricular walls, but the problem with giving contrast is that you will have trouble seeing where you are placing your sample volume. So if you want to measure stroke volume, you won't be able to do that or tell where your sample volume is if the ventricle is full of contrast. There's a question about how often we use contrast for our stress echoes. For our dobutamine stress echoes, which tend to be performed in patients who are heavier and more apt to have lung disease, we use contrast, echo contrast in about 40%. With our exercise studies, we use it in about 20%. For our valvular hemodynamic studies, we use it less. There's a question about atrial fibrillation and how that impacts the role of stress echo in valvular heart disease. It does make it challenging, indeed, but it doesn't make it impossible. You will need to average data over multiple cardiac cycles. You won't have time to do that during the stress test, so you'll just acquire your images and measure them later. It helps, of course, if the cycle length is more constant rather than all over the place. And it's important that the rate is reasonably well controlled. If the patient comes to your laboratory and they're already at their target heart rate because of atrial fibrillation and rapid ventricular response, then there's no point or need to do a stress test. The atrial fibrillation needs to be treated first. Thank you for your excellent questions, and I hope that you find our paper useful and that you've found this webinar helpful. Take care and feel free to contact me with additional questions. Have a great day.